Hi guys, today I just want to talk about brainstem lesions. Now, brainstem lesions is another thing which a lot of people get confused by. Even I get confused by, but I made this fact sheet a couple of years ago, which I posted on my Instagram page. So I made this fact sheet with all the brainstem lesions, and I just want to tell you it's not hard at all. You just need to learn a few basic principles, and if you get the principles, then it will be very easy. The first thing we have to know about brainstem lesions is obviously the brainstem consists of three parts: the midbrain, the pons, and the medulla. My medulla is in pink, the pons right here, and then the midbrain. The second thing we need to know is that we need to be able to identify what is medial lesions and what are lateral lesions. All medial lesions that affect the brainstem need to have corticospinal tract involvement and medial lemniscus involvement. So I suggest that when you're undergoing a stroke question or a question that involves brainstem lesions, first thing you need to do is look for whether they are corticospinal tract lesions or medial lemniscus lesions. What this means is that the question stem is going to say that the patient has contralateral it's right here actually, contralateral paralysis, and also the patient has contralateral loss of vibratory sensations. Now, contralateral, because we know that these two decussate, so it's decussates in the medulla, so it's not going to be on the ipsilateral side. So that's the first thing you need to do when looking at brainstem lesions, right? So now these are for medial lesions. Now for lateral lesions, we need to whether the patient has involvement of lateral spinothalamic tract involvement or CN5 and CN8. Okay, so if the question says that the patient has ipsilateral loss of pain and temperature in the face, which is CN5, and also the patient has ipsilateral hearing loss, which is CN8, and they're talking about contralateral pain and temperature on the opposite side of the body, then we know we're dealing with a lateral lesion. So this is the first thing you need to do: identify whether it's medial or lateral, right? So if we identify whether it's medial or lateral, this will make it easier, because now we're going to break it down as either medial midbrain, lateral midbrain, medial pons, lateral pons, medial medulla, lateral medulla, and it gets really easy from there. So we know that the third thing we need to know now is how do we tell whether it's in the midbrain, the pons, or the medulla. And I like to follow the 3-6-12 rule. So 3 is for the midbrain, 6 is for the pons, and 12 is for the medulla. So 3 stands for cranial nerve 3, and 6 stands for the abducens nerve, and 12 stands for the hypoglossal nerve. So cranial nerve 3, we know that is the oculomotor nerve. The oculomotor nerve is responsible for innervating the superior rectus, the medial rectus, the inferior rectus, and the inferior oblique, right? So we know that. And the abducens is responsible for innervating the, what you call as the abducens nerve, and the cranial nerve 12, the hypoglossal nerve, is responsible for innervating the tongue. Now, all cranial nerves are ipsilateral, so they're gonna the sides of the lesion is going to be have the same. What I'm trying to say is that the side in which the nerve is affected is going to be the same side of which the lesion occurred, right? Whereas when we're talking about the corticospinal tracts and the medial lemniscus tracts, these were contralateral. Also, the spinothalamic tract was also contralateral because these decussate. Whereas the cranial nerves, they don't decussate, they don't go anywhere, they go straight to whatever side they're innervating, right? So if we have a cranial nerve lesion number 3, I just said that the cranial nerve number 3 innervates the certain nerves, which is superior oblique, inferior oblique, superior rectus, inferior rectus, medial rectus, and inferior oblique, right? So I just said that. So if we have a cranial 3 lesion, we're going to have an ipsilateral eye, which is which looks on the which looks laterally, or what they like to call as down and out. So it's going to look laterally because of loss of the medial rectus, and it's going to look down because of the loss of the inferior rectus. Because remember, the inferior rectus is responsible for rotating the eye up. The eye is also going to be dilated because the cranial nerve 3 is also responsible for constricting the eye. So if we lose the cranial nerve 3, the eye is going to be dilated. Also, there are going to be ptosis, right? Because the cranial nerve 3 is also responsible for innervating levator palpebrae. So please don't confuse this with Horner syndrome. Horner syndrome, it has ptosis as well, but there's meiosis, and there's also anhidrosis on the ipsilateral side. But the eye, there's no lateral displacement of the eye, whereas in cranial nerve 3, the eye is out and down, dilated, and there is ptosis, right? So if the question stem was talking about something where the patient has ipsilateral down and out eye that is dilated, and there is the patient has hemiparesis on the opposite side, and also they can feel pain and vibratory sensation on the opposite side, we know we're dealing with a medial midbrain lesion. Whereas if there is also cranial nerve 3 lesion, like we just said, and then they were talking about, they said instead of corticospinal medial lemniscus, they said that the patient has contralateral loss of pain and temperature, but they have ipsilateral loss of pain and temperature on the face, and they also can't hear on the ipsilateral side, then we know we're talking about a lateral brainstem lesion, right? Now, it goes similarly, it's similar to pons, we just have involvement of the abducens. Now we know that the abducens is responsible for lateral rotation of the eye. So what's going to happen if we lose the abducens nerve on that side? We're going to have ipsilateral loss of lateral rotation of the eye. So that's how we know it's in the pons. Whether we know it's medial or lateral depends on whether there's contralateral loss of, or there's contralateral paralysis, and there's contralateral loss of vibratory sensation, so that means it's medial pons. But if they're saying that the patient has loss of ipsilateral lateral rotation of the eye, plus they're saying that the patient has lateral spinothalamic pain and temperature, and also ipsilateral loss of pain and temperature on the face, and also hearing loss, we know that it's lateral pons, right? In lateral pons, they're also going to have now, for lateral pons, if they said that the patient has contralateral loss of pain and temperature of the body, and then they have ipsilateral loss of pain and temperature of the face, and ipsilateral loss of hearing, but instead of having a cranial 6 lesion where they can't laterally rotate the eye, instead we have ipsilateral facial paralysis and decreased lacrimation and salivation. We know that we're dealing with a lateral pons lesion. Also, the middle cerebellar peduncular is going to be involved, so the patient is going to have ataxia. Similarly, in the lateral medulla, they're also going to be ataxia because they're involvement of the inferior cerebellar pons. It doesn't matter which cerebellar peduncle is involved, as long as the cerebellar peduncle is involved on the lateral side, it's going to cause ataxia. Just know that in the lateral pons is the middle cerebellar peduncular, but both of them are going to cause ataxia, right? Now, when we get to the medulla, right, we're in the medulla. Again, medial, first recognize whether the question has involvement of the corticospinal tract and the medial lemniscus, then we know that it's medial. If the question has involvement of the lateral spinothalamic or cranial nerve 5 and cranial nerve 8, we know that it's lateral. So if there is involvement of 12, which is the hypoglossal nerve, we know that the patient is going to have ipsilateral tongue paralysis. So if we ask the patient to protrude their tongue outwards, the tongue is going to move to the opposite side because the side that is affected or weak is too weak, so the opposite side pushes on it and goes and pushes the tongue on the opposite side. I hope I explained that, right? And whereas on the lateral medullary side, also known as the famous Waldenberg syndrome, we have involvement of cranial nerve 10 or the vagus nerve. This is going to cause dysphagia, hoarseness, and decreased gag reflex, and it also involves the inferior cerebellar peduncle, so it's going to cause ataxia. Now, guys, this is not hard to understand at all, as long as you understand that medial lesions affect the corticospinal tract and the medial lemniscus. And how do you know whether it's medial midbrain, pons, or medulla? You look for involvement of cranial nerve 3, 6, or 12. How do you know if it's lateral? You look for involvement of loss of pain and temperature on the entire half of the body, and involvement of cranial nerve 5 and 8. That's how I know it's lateral. Whether you know it's cranial nerve whether you know it's midbrain, pons, or medulla, you look at whether it involves facial nerve or vagus nerve, right? So now we're getting to a close of this. So now let's talk about the arteries that can be involved in these things. So there are a ton of arteries that can be involved, but I'm going to give you the main ones. I tried to draw here. I tried to scheme a little blood vessels on this brainstem. So here we have the vertebral arteries, the two vertebral arteries joining to form the basilar artery. So the vertebral artery gives off the pica, or the posterior inferior cerebral artery. This is why pica causes lateral medullary syndrome, because it branches. The pica comes off in the medulla and then it's on the lateral side, so it's going to cause lateral medullary syndrome. Now the two vertebral arteries, they join upwards to form the basilar artery, but they also join downwards to form the anterior spinal artery. Now if you affect the anterior spinal artery, it's going to cause middle medullary syndrome, right? So this is how it works, guys. So this is the two arteries that are most important for this entire brainstem lesions. And even ANCA, which is anterior inferior cerebral artery, it causes lateral pointine syndrome. Okay, so guys, this is a quick fact check or fact sheet of brainstem lesions, and I hope this was easy or simple to understand, and I hope that was helpful.